Hello, everyone, and welcome. This is Julie Schills, and I'm the PCPCC Executive Member Liaison to the PCC Board. I do this role along with Rob Driven from Merck. I'm currently the Senior Director of Health Innovations at Mathematica, and I'm pleased to be serving as facilitator for today's webinar on ways to bring value in healthcare, successful ACOs, and strong foundations of primary care. But first, before we get started, a few announcements, and they're quite exciting. Less than 2 weeks away, we have the PCPCC Annual Conference, Key Policies to Elevate Primary Care. This event will take place in Washington, D.C. on November 8th. The agenda is just amazing. It'll address key strategies to elevate primary care to include educational sessions and in-depth discussions on how we can make our vision for primary care one that is person-centered, team-based, and community-aligned a reality. Participants will have the opportunity to work in small groups to consider how to spread and scale the ideas presented at the conference or propose alternative strategies to elevate primary care. There's plenty of networking opportunities, and if that wasn't enough to get you signed up, you can also earn CME credit. The keynote speaker for this event is Alex Azar, Secretary of Health and Human Services, and having just heard him speak at the HCP Land Summit, it is definitely worth being able to listen to the administration and the direction, hearing from them the direction they're going. So we have an impressive list of speakers and diverse panels. I encourage you to go to pcpccevents.com. All this information is in the slides, and those slides will be made available to you, but you can also go on the PCPCC website and be able to get to this information. That night on November 8th, PCPCC will also be celebrating the accomplishments of primary care champions. This year's Barbara Starfield Awards goes to Dr. Karen DeSalvo. I had the opportunity to work with Karen during ONC Beacon program before she became the administrator. Dr. Charmaine Lawson, a nurse practitioner, is receiving the Primary Care Community Research Leadership Award, and Apple Care Medical Group, part of Optum Care, will be receiving the Advanced Primary Care Practice Award. It's always an energizing evening, and feel free to go to PCPCC's website to purchase your tickets. So with that, I will introduce our panelists today so we can get started on this amazing presentation. First, we have Travis Broom. He leads Adelaide's policy efforts in both Medicare and commercial space to ensure the viable financial model for accountable care organizations and population health. Travis joined Adelaide from the Center for Medicare and Medicaid Services. We also have Dr. Yalda Javahor, who is a family physician and medical director at the Graham Center. In this role, she oversees the Visiting Scholars Program and conducts research on high-performing primary care and practice transformation. Worked with us here at PCPCC for our this year's evidence-based report. We also have Dr. Michael McWilliams, who is the Warren Alpert Foundation Professor of Healthcare Policy and a Professor of Medicine at Harvard Medical School. He is also a practicing general internist at Brigham and Women's Hospital, and he's going to be talking about some of his research that he recently did. So with that, I'm going to turn it over to Dr. McWilliams to start our presentations.
Great, thank you very much. I am thrilled to be doing this webinar and look forward to everyone's questions. So I am trying to advance. Let's see if, Okay. Oh, spoiler alert. Looks like it advanced too far. Okay, so if you have been following the ACO debate at all, you have probably come away with a sense that they have not delivered on their promise. That is the general view out there. But I think the reason for that view is has less to do with how successful ACOs have been and more to do with the amount of hype that there was at the outset of these initiatives. So for example, This was an image that actually ran in the Washington Post along with an article covering one of my early studies on ACOs, and this was the lead. Accountable care organizations may actually be the unicorns we've been waiting for, spreading their cost-saving magic throughout the health system. So why the rainbows and unicorns? Why the hype? What is so magical about ACOs? What's this cost-saving magic? Well, if you did a Google search back then, you would have found things like this. So from CMS's website, they describe ACOs as one way that we're working to better coordinate your care. How ACOs work: local healthcare providers and hospitals volunteer to work together to provide you with coordinated care. The doctors and other providers who are helping care for you will communicate with each other. And you would have found lots of other, and still would find lots of other headlines extolling the virtues of care coordination. So that's the way that ACOs were conceptualized, that care coordination was the key to savings, that if we could get providers to talk to one another, if we could follow patients across care settings, coordinating otherwise fragmented care, if we could reach out to patients, fill gaps in care, make sure patients get the care that they need when they need it. If we could do all of that, then that would reduce redundancies, prevent errors, and also prevent costly complications, thereby lowering spending. That meant that it was thought also that provider consolidation would be a key to success, a prerequisite to success, to achieve the necessary clinical integration across the full spectrum of care and really control the full spectrum to achieve those efficiencies through coordination. Part of the idea here was a reincarnation of the idea that prevention saves money. And I think more generally, the notion that if we could only do more for patients, that somehow we would then spend less. And while all this would be wonderful if it was true, unfortunately, the evidence supporting these assertions is pretty scant. So if ACOs aren't unicorns, what are they? I think probably everyone on the line is pretty familiar with ACOs and these programs. I won't spend time reviewing the specifics, but here is a little background information. The thing I wanted to stress here is I think it goes underappreciated how weak the incentives are in the ACO programs. I'll be talking most specifically about the Medicare Shared Savings Program, but how weak the incentives are for ACOs to lower spending, and that's for a variety of reasons. One of the main reasons is the so-called rebasing of an ACO's benchmark. So if an ACO successfully lowers spending in its first 3 years, its subsequent benchmark for its following contract period is essentially lowered by the amount that it lowered spending. So that leaves an ACO with very little incentive to ever lower spending if it's penalized with lower benchmarks later. Another way to think about that is it gives, to the extent that lowering spending requires things that incur fixed costs, an ACO has very little time to make up those costs. Another reason is the low shared savings rates. So the maximum has been 50%, but it's really lower than that in the 40s because few ACOs achieve perfect quality scores, and the rate is reduced for any imperfections from on the quality scores. And then finally, it costs a lot to be an ACO, the cost of governance, the cost of trying to improve quality, the cost of trying to lower spending, and then also costs in the form of offsets and spillovers. So particularly for the large health systems, if they are going to lower spending for their patients, that typically means they need to provide less care. And providing less care means that they lose fee-for-service profits, which then offset at least partially any shared savings bonus that they get from lowering spending. And similarly, if an ACO does things to lower spending for its ACO patients, that could spill over onto other patients, eroding its revenue that are not under such risk contracts. In terms of policy backdrop, as I think many know, the 2018 proposed rule for the Medicare Shared Savings Program is under deliberation at CMS. We can discuss that in greater detail. I think the basic thrust of the proposed rule is to try to impose more downside risk, accelerate the transition of benchmarks away from using historical averages to regional averages, and to really sort of get tough on ACOs that are not performing. None of that in isolation is necessarily bad or misguided, but I think in a voluntary program, that direction could be counterproductive in terms of losing participants. All right, so what does the evidence tell us? Have ACOs generated savings? If you look at the CMS data, up until very recently, they would suggest no, they haven't. For example, from 2013 to 15, the data would suggest that ACOs in the Medicare Shared Savings Program lost Medicare on net $344 million. Our research by myself and colleagues here at Harvard Medical School would suggest that actually, yes, it has saved Medicare, actually $358 million during those same years. So what explains that big discrepancy? Well, it turns out, for various reasons, that the benchmarks that are used in the program are not valid, what we would call counterfactuals. That is, they do not represent the spending that we would expect in the absence of ACOs being ACOs or doing what ACOs try to do. And this has been a source of endless confusion, at least for those who don't follow Mark Friedberg on Twitter. All right, so what is driving these savings? I'm going to start by talking about what is not driving the savings. And contrary to, I think, many people's expectations, it's not the health systems. It's not the big hospital integrated organizations. So you can see from this first bar here, just a 0.4% reduction in total spending compared with the 3.1% reduction among physician group ACOs by 2015. And that is very consistent with the much stronger incentives experienced by the physician groups in the program for the reasons I just mentioned. That they do not face these sort of lost profits offsets when they lower spending. The incentives are really in the program to lower the amount of care provided by other providers, and that's much easier for physician groups to do. This includes a 2.3% reduction in admissions, but when we look at so-called preventable admissions or admissions for ambulatory care sensitive conditions, we find zero effect for both the hospital integrated ACOs and the physician group ACOs. And then if the savings were really being driven by coordination across transitions in care, we would probably expect reductions in readmissions as a contribution to the savings. But we actually find a significant increase in readmissions among the hospital integrated ACOs and a very modest, not significant reduction in readmissions among the physician group ACOs. The savings among the physician group ACOs, as you can see here, for a given entry cohort, these are the ACOs entering in 2012. They grow progressively over time with more years of participation in each of these cohorts. Not the case for the hospital integrated ACOs, where they either get off the ground and plateau or just kind of never get off the ground or revert. And they're the net savings estimates in 2015 for the two ACO groups. How about savings from better disease management? Another expectation, better disease control, fewer costly complications. We can't measure disease control very well in the data that we study, but one would think that it would be mediated, at least in part, by better adherence to important medications and use of important medications to control blood pressure and cholesterol and diabetes. The point of this slide, as you can just see from all these effects hugging the zero effect line, is that we really don't see much of an effect on medication use and adherence. How about high-risk patients? So a lot of the care coordination and management efforts focused on high-risk patients. If those programs were driving the savings, then we would expect to see greater savings among high-risk patients. But as you can see here, the red bars, we find that the percent reduction in spending is actually quite similar for the entire population, the low-risk patients and the high-risk patients. In contrast, when we look at patient experiences, so overall care ratings, for example, we find this quite meaningful effect among the high-risk patients, not among the low-risk patients. This effect of about 1.7 effect size is equivalent from moving from average performance among ACOs to about the 96th percentile, so a pretty meaningful effect. So I think this tells us that these high-risk case management programs probably aren't the lead explanation for the savings, but patients sure seem to be benefiting from them. So what is driving the savings? We can't tell for sure. And a lot is going on, but when we look at the savings by type of service, what jumps out is probably that at least some ACOs are engaging in more direct means to lower spending, sort of good old-fashioned utilization management. So these bigger reductions in spending on hospital outpatient care, post-acute care, to a lesser degree, home health care that's initiated on an outpatient basis, and on inpatient spending, but not for the preventable or so-called preventable admissions. So this is much more consistent with ACOs steering patients away from high-priced hospital outpatient departments into the office setting, exploiting the price differential there in Medicare, getting patients home instead of having them go to facilities at discharge, or shortening length of stay in post-acute facilities, or shifting them away from the ED to the office setting. Some may think of those activities as care coordination, but I think semantics aside, the distinction is sort of between strategies where that really rely on making investments in patients and their outcomes to have sort of a downstream payoff in terms of better health versus strategies that more directly ensure that less is done or less is spent. So in conclusion, we do find net savings to Medicare. So despite the weak incentives, and I think if you hear the contrary, the evidence would speak that there are indeed savings. I think that's interesting too. It's almost astonishing that we see any savings how weak the incentives are, and it speaks to the willingness and the altruism of a lot of the providers involved. It begs the question in terms of the rule setting, how do we strengthen the incentives further to get more savings without costly participation losses? The savings don't seem to track necessarily with care coordination or care case management efforts and stories that we sort of expected at the outset. They do seem to track with the strength of incentives. I think this also means that we really need to spend more time thinking about how to cut waste and having honest conversations about spending less by doing less. It's really amazing how much health management firms and consulting firms are selling predictive analytics and care management platforms, and how little they are selling the science of waste reduction. Why the greater savings among physician groups? As a physician myself, a practicing PCP, I would really love to believe that it is the effect of primary care and the stronger leadership and intrinsic motivation that physicians might have to offer, but I'm not sure if we can really say that based on the evidence. Certainly the incentives are stronger for physician groups. Others talk about the agility or how nimble physician groups are relative to the big health systems because they don't have the capital investments that they need to shed in order to respond to the incentives. I think of that as more of an incentive story. And then finally, I'll just end with this thought, and that is that the topic of this webinar is really the extent to which primary care is key to supporting ACO success. But I think turning that on its head raises a potentially even more important question, which is the ACO model key to supporting primary care success? Whether or not primary care per se is what's mediating the savings in the physician groups, the ACO model is clearly a way more viable payment model for primary care focused physician groups than for other types of organizations. And in payment reform, it's really important who gets to keep the savings. So if you think about bundle payments, for example, with hospitals keeping the savings, with post-acute becoming the ATM for hospitals rather than physician groups, that might entrench the market power of hospitals. And then we should ask ourselves, do we think hospitals or physician groups are more likely to use the savings to invest in primary care and advanced care models? So I think what this is suggesting is that the ACO model is likely to encourage investments in primary care, if not entry of really innovative, disruptive care models. And we are on way more firm grounding by asserting that new care models and investments in primary care are probably good for patients than we are in saying that good primary care saves us money. Thanks very much.
Okay, thank you, Dr. McWilliams. This is Yalda Jabapour. I'm the medical director at the Robert Graham Center, and I'm going to take you through the findings of this year's Patient-Centered Primary Care Collaborative Report, which we helped out with here at the Graham Center. And we were looking at the impact of advanced primary care on ACOs in an attempt to try to answer the questions that Dr. McWilliams brought up in his presentation previously. So let's see here. I wanted to actually take a moment to thank my co-authors on this report. It really was a team effort of people here at the Graham Center, at PCPCC, at Milbank, at IBM. I'm presenting today, but it's really the team effort of all these people today. So for the past 7 years, the Patient-Centered Primary Care Collaborative has put out a review of the literature surrounding the patient-centered medical home in particular. And I wanted to start with a little bit of background as to why we took the report in a slightly different direction and decided to look at this intersection between accountable care organizations and advanced primary care. Last year's review, and this is kind of the take-home slide from last year's review, of the PCMH showed generally positive results, though not always uniformly so. And although as primary care physicians, we might all agree that the PCMH has had a positive impact on how we deliver primary care, a number of reasons exist for why the model is not achieving all the results we hoped for. So among these are our underinvestment in primary care in this country. Estimates change to how much we're spending, but if we're spending on average about 6 cents on the dollar on primary care, it's hard to imagine that primary care alone can make a dent in the cost savings of the healthcare system. But the other reason is the ecosystem in which primary care works needs to be more involved in making changes for patients. The burden really cannot be on primary care alone. And as Dr. McWilliams stated, in theory, the ACOs were this unicorn that would incentivize all providers along the care continuum, not just primary care, to provide this high-value care. And given that advanced primary care is built upon a foundation of care coordination, team-based care, high-value care, we hypothesized that we would find a great deal of literature showing the strong connection between the two. And although there's a lot of theoretic literature out there, editorials on how advanced primary care can really help the ACOs succeed, as Dr. McWilliams pointed out, the evidence really isn't as clear as we thought it would be. And so I'm going to tell you how we went about with this year's report to try to figure out what the connection is. But really, before I dive in, I wanted to define advanced primary care. So in the report, when we talk about advanced primary care, when we do our literature review, we are really talking about practices that abide by the shared principles of primary care, which were developed in 2017 by input from primary care organizations, community partners, as an ideal vision of how primary care should be delivered. So this is essentially primary care that is accessible, comprehensive, person-centered, and high value. And this report really took on 3 sections this year. So in the past, as I said, it was just a literature review. Section 1 and Section 2 of this year's report were also literature reviews and synthesis of that literature. But Section 3 was a quantitative analysis where we used data from the National Committee on Quality Assurance and the Medicare Shared Savings Program data to try to actually look at the impact of advanced primary care on ACOs. So in our first literature review, really the question we were asking was, what are the characteristics of successful accountable care organizations as a whole? Not necessarily those that are based in advanced primary care, but those ACOs that have succeeded, what have they done to succeed? And we define success maybe a little bit differently than it has been in the literature before. Accountable care organizations, I think, at their heart are a payment model. So when we define success, we look at shared savings, but we really defined success as either shared savings or improvements in quality. Because as Dr. McWilliams said, and as we hypothesized, a lot of the improvements that primary care can make have to do with the quality of care we're giving to our patients. And so we started out with about 186 articles. We really used a team of library scientists to help us find the articles, and then 2 separate reviewers screened these articles with our preset exclusion and inclusion criteria, and we came up with 15 articles that we then thematically analyzed. And when we looked at the articles, we came up with these 6 themes. It seemed to be that ACOs that were succeeding had engaged leadership that bought into a team-based culture and really propagated this culture throughout their organization. They had experience with practice transformation and had the capacity to undertake transformation. They had a robust IT system that gave physicians timely information about their patients' care, inpatient admissions, discharges, ER visits, specialist reports. They had effective care management. So it was one thing to have a care manager, but it seemed like these ACOs were very thoughtful in the deployment of their care managers. Many of them used IT to risk stratify their care management services to those patients who were at highest risk. environmental factors really mattered. So this included things like rurality and access to high-value specialists or care settings, and also financial benchmarks, as Dr. McWilliams pointed out. And finally, the ACOs that were doing well reported having a critical mass of their patients in the ACO, so that the practices were incentivized to transform, or that if they had multiple ACO payers within their system, these payers were aligned on payment and measurement. And what we really noticed was that these 6 themes that were developed in the literature review and were echoed by the expert convening that we held is that the characteristics that contributed to success in the ACO program were really closely linked to these shared principles of primary care. So in section 2, we actually wanted to take a closer look at the question we were trying to answer, which was, okay, so what is the effect of advanced primary care on cost, quality, and utilization outcomes? Once again, via a literature review. We looked at ACOs that were centered on advanced primary care in the literature. This did not necessarily, though, mean that they were physician-owned or hospital-owned, because I think the distinction is important. There were some hospital-owned ACOs that we looked at that really did show evidence of being centered on advanced primary care and vice versa. So it wasn't so much the ownership or the governance, it was this being centered on advanced primary care principles. And the outcomes of interest we looked at in the literature review were cost, quality, and utilization. And we started, once again, with about 260 articles, but really once we read the full text, we're looking at about 10 articles that fit our criteria. And here are the outcomes. In general, we found that when we looked at quality, the articles showed that those ACOs that were based on advanced primary care did well in terms of quality. In cost, many of them did well, although some of the results were mixed. And then in terms of utilization, we really looked at inpatient utilization and ED utilization, so whether those two went down and whether PCP utilization went up. And we found generally mixed findings there. But I have to say that the literature review, as we've alluded to, was a little bit limited in terms of trying to make any kind of strong conclusions. We only found 10 articles, and most of these articles looked at pre-post ACO implementation in a system that already had advanced primary care. So it was hard to tell what the effect of advanced primary care was. Only one looked at the impact of PCMH transformation within an ACO. So this really led us to our section 3, which was our quantitative analysis. And here we use data from NCQA as well as cost and quality data from the Medicare Shared Savings Program, which is the largest of the Medicare ACO programs. We used NCQA as a proxy for PCMH status only because it had the largest share of certified PCMH. And so what we wanted to look at was, do ACOs with a higher share of advanced primary care models perform better? And the outcomes we were looking at really were the shared savings and quality measures. And so using these two data sets, we were able to identify the proportion of PCMH certified physicians within each ACO. And then we divided those ACOs into quartiles, with quartile 1 having the lowest share of PCMH physicians, and quartile 4 having the highest shares of PCMH certified physicians. And what we found was we looked at all of the quality measures in the MSSP data. This was 26 measures plus 2 composite measures, specifically a diabetes and coronary artery disease composite measure. These measures included a mix of patient experience, outcomes, and process measures. We found that ACOs with the higher PCMH PCP share did better in terms of quality. On this slide, I list the statistically significant differences, but if you look at table 3 in the report, which I think is linked here in the webinar, you'll see that this pattern holds true for a majority of measures, with quartiles 2, 3, and 4 outperforming quartile 1 in terms of quality. And then in terms of shared savings, because after all, this is one of the ways that the ACO program is judged, we also saw that ACOs in quartile 2, 3, and 4 had a higher rate of shared savings when compared to quartile 1. But as you can see by this graphic here, it's not necessarily stepwise, meaning that quartile 2 had the highest rate of savings, not quartile 4, which would be expected if PCMH was the driver of savings. So in conclusion, our literature review showed that the 6 ACO success factors were closely aligned with the shared principles for primary care, and that ACOs with a primary care orientation had generally positive cost outcomes, positive quality outcomes, and mix on the utilization outcomes. And our quantitative analysis started to show that Medicare ACOs with a higher proportion of PCMH primary care physicians were more likely to generate savings and have higher quality scores. But as Dr. McWilliams alluded to, we can't yet draw any causal conclusions, and it's really hard to tell the directionality of this relationship. So is it that advanced primary care, which is well positioned to provide high value care to patients, is driving success? Is it that ACOs help bolster advanced primary care? Is it both? At this point, it's hard to say. There does seem to be a relationship between advanced primary care and successful ACOs, and it's really something that I think future quantitative research really needs to explore. So thank you for the time.
Great, thank you. This is Travis Brum. I'm from a company called Alidade. We do physician-led, primary care physician-led ACOs, but really our distinguishing characteristic as physician-led can be kind of generic sometimes, is physician-owned practices. So all of our practices are owned by physicians. So I'm going to take the N down some, not all the way down to 1, N equal 1, but much further down than the research we've gone over before, and talk a little bit about our experience in working with these ACOs. You can see all the stats on the slide. I certainly won't read them all out to you. The biggest piece being the 450,000 attributed patients in shared savings arrangements, both commercial and Medicare. To the rest of the slides, we're really going to be focusing in a little bit on about 2/3 of those patients, those for whom we have at least a full year of results. Alidade is 4 years old, so our oldest ACO started in 2015, going out to 16 and 17, mainly talk about 15, 16, and 17 ACOs. Let's see. There we go. So we really want to talk a little bit about the outcomes we've been seeing and how we think we've gotten to them and what's really resonated with our physicians as we've talked about and seek to motivate them. Here you can see results. We do it by cohort. One of the things that we firmly believe is population health takes time. Dr. McWilliams mentioned in his slides about the overly optimistic expectations of year 1 results from the MSSP program. I know when I saw the MSSP results in the first cohort back in 2014 and even into 2015 for the 14 year, and everybody was buying them, I was kind of like, well, welcome to population health. You've obviously signaled that you're new to this. It does take time. We all have great stories. Anybody who's been doing an ACO, who's doing any kind of work, has a single great story about how a hospitalization was prevented and an individual patient was helped. It takes time for all of those individual stories and all of that change to build up into something we can see at a population level, which is what you can see here on the slide. The darkest color is the oldest cohort, and you can see with only a few exceptions, is far and away the most change on outpatient. I will basically point out an Alliday difference from our experience versus the national experience that Dr. Williams laid out for other physician-led ACOs. Basically, we reduced hospitalizations more than the average, but we have not had as much luck as others with hospital outpatient spend. Certainly, we believe there's some substitution going on there with inpatient versus outpatient, but to the extent that nets out in cost savings, we're somewhat okay with that. But for the most part, you can see a very familiar story, right? When we talk about, when I tell my ACOs, what do you have to do? To get savings? You have to reduce skilled nursing post-acute. You have to reduce hospitalizations, and usually you have to do something else, and that something else usually varies by market. Some markets have been more successful at bringing down outpatient costs. Other markets might have had, excessive home health use or excessive specialization, specialist physician use. You can see in the upper left-hand corner there, use of a specialist goes down as well, as you might expect from our primary care focus. But I just spend the bulk of my time here really talking about the next two slides, which is like, how do we think we go about this? And a lot of it comes down to that primary care focus and that primary care positioning combined with very actionable things. So the first thing when we talk to our physicians about, should they even be in an ACO? Tell them, look, all an ACO is a group of physicians who come together and say, these are my patients. I'm going to be responsible for the total cost and quality of their care, whether they come see me tomorrow or not. That resonates most with primary care physicians. It's back to like they have the best kind of alignment piece. So we really want our physicians to believe in that as a core, because the behavioral economics of shared savings aren't spectacular. In fact, they kind of suck, right? Like you're basically going to work harder for Mrs. Smith. You're going to get your staff to hound her to get her in because she needs to come in for her annual wellness visit. We need to touch base with her and take that visit. That's kind of a step back, not what hurts today, but we're going to look at your health and your total situation. We're going to hound her tomorrow in the hopes that when I combine her with 10,000 other Mrs. Smiths and compare it against a benchmark that the government did that we don't really understand, or at least not me as the physician, I don't really understand, that extra work is going to have a financial return. So really what I'm looking for is physicians who believe this is primary care's place. And certainly some specialists who believe it's their place for that total cost of care and quality. And then, it's kind of my job here at Alliday to convince them that there is an economic model, that there will be a return on those investments eventually, and that it will pay off, and that it is important that you get a % of savings and not a new type of fee for service like these PM payments in order to have a financial model for the future. So this is here on the slide, one of our big tools is an annual wellness visit. One of our learnings over the last 4 years has been that it matters which patients you target. Our target's 80%, not 100%, mainly because there are some relatively pretty healthy Medicare beneficiaries for out there. And it's not that they wouldn't benefit from an annual wellness visit, but if you only have so much time on the schedule, getting them in every year is not as important in generating health that is reflected in reduced cost and better quality as others. So we give them a targeted list, focus on these things, and taking this step back visit for our ACOs. And you can see from 16 to 17, quite the increase. The individual lines are individual ACOs that were in both 16 and 17 there. The other main tool we talk about is transitional care management. So this is another thing we talk to our physicians, and it comes back to, you need both financial incentives aligned with a mindset like this is why we want to practice medicine. So one of those things is like just, it's not the patient's job necessarily to come see me and to call the office because they're in the hospital. I want to reach out to them because they're in the hospital, because they left the hospital. So step one for us from a data perspective is knowing, right? Were they in the hospital, and knowing in time. You can't wait for the claim, right? You have to know in time how to actually know that the patients are both share a PCP and are in the hospital and about to be discharged their hospital, and doing those visits, those transitional care management visits, timely for the patients who need them. And again, on the slide, you can see those 16 to 17 change, individual lines being individual ACOs. So how does all this translate into savings in our experience? Again, this is looking at 2016, because that's the best data we have. This is stealing for the left three columns, the Office of the Actuary, well, and we use the same methodology for ourselves, the Office of the Actuary analysis that they did in the recent CMS proposed rule. They grouped two buckets, low and high revenue ACOs. These are basically, it correlates with physician versus hospital led or owned. But really, it's talking about how much of a demand destruction problem do the groups have on average, and then the next gen ACO, and then the Aledade experience. And this is about what we at Aledade are striving for, is to take physician-led ACOs and make them a little better and a little more comprehensive. Just at least in 2016, that appeared to be the case. And what I'm going to leave you with kind of a story that kind of ties all these things that I use a lot when I talk to physicians about the economics of shared savings. So you're a primary care physician. You take a call on Friday evening from a patient who describes chronic chest pain to you, same way they've described it to you many times before. You tell them, I think that's going to be okay. Make sure you take your medicine. Make sure you call me back on the weekend if something changes, and we can see you on Monday, but you don't need to go to the emergency room. And obviously, if you show up at the emergency room to a bunch of strangers, with chronic chest pain, you are getting the workup out the wazoo. So the patient's happier, they avoid the heartache, they don't spend the week in the hospital. The physician saved that cost. We'll just call it $10,000, right? $5,000 in savings. But that story is kind of riddled with a lot of what we've been talking about today. For one, in our case, our primary care physician, yeah, he saved $5,000, but he wasn't the one who was going to get the $10,000. So back to the demand destruction problem. That physician works for a hospital. Yes, they still save $10,000, but that might have been $10,000 in revenue to their employer, as opposed to a physician-owned practice for whom it was all gravy. There were several other assumptions in that story. One, that the patient has described their chronic chest pain to their physician many times before, and they don't use their cardiologist for their chest pain. They use their primary care physician. They don't have three primary care physicians that they just bounce around between and plus two cardiologists. That they actually have a relationship with the physician they're calling. They also have a strong enough relationship that they made the call in the first place, because they were comfortable calling the hotline or the after hours line at the practice on a Friday evening. And then the practice had the workflows in place that when someone actually calls the line on a Friday evening, it does actually get through to someone who can help that patient, someone who knows that patient. All of those things, or all of the workflow pieces and the economics and everything that has to come together to create that story we all tell and know and love. But it really is a very systematic effort and a very data-driven, workflow-driven but at the same time trying to keep it simple effort to do that for all of the patients that are in your ACO and all of the people, and to do it for enough people and reliably enough and often enough so that it makes a difference on population levels and not just great storytelling for a few patients. So with that, I think it's time for us to switch over to the Q&A.
Thanks so much, Travis. We happen to have received a few questions even prior to the webinar, and one of them I think is relevant for you, so I'll go ahead and use our transition time to give you the first question, and certainly our other panelists, if you have, you can answer as well. But the first question is really about the data for the care teams. And there are a few new questions that sort of relate to this as well, but a little bit about how Aledade thinks about compiling the data, but putting it in a way that the care teams can actually use the information for care delivery. And then the second part of this question, interesting question, is really, is there any support that you provide for any of the ACOs that really help the clinical and frontline staff sort of understand how to interpret the data and how to move forward with the data once they receive it?
Sure. So, I put on Twitter a little while ago, kind of what is population health, and the first step of population is being able to look at a population and find people in that population who should be linked up with another person or a resource that can help them. Right? That's always step one for us. Is what can we know about the population? How can we look at a population to find individual people who we can hook up with a resource, be it another person at the practice, or maybe not at the practice, or even just a resource themselves, an organization, and make that connection. A lot of this comes down to, it's usually very, very, all the work is like finding the right person and knowing both sides of the database, right? Knowing a lot about your population, but also knowing a lot about the practices you work with and the resources that are available. But then when it comes to making the link, I could, pull up the app, the Aledade application, right? The Aledade app. And a lot of it just comes down to work lists. It looks a little cooler than a piece of paper. It's more interactive if you want to know more about the patient. But at the end of the day, it is just a list of people that are grouped together because prevention, they had a transition, they should be enrolled in care high-risk patient management, and giving that to a person who can connect with the person who's identified to really come together. And then on the back end for population health, it really comes back around to looking at, did what we do work? We took a initial shot at care management and really found that we helped a lot of people, but we weren't really changing utilization. So we had to rethink how we were doing care management as well, because we also always got to remember to come back on the other side and see, I did link 150 people with resources, but did it actually make a difference?
Thank you. Yelda, I have a question for you, and I'll read it. With the ACO rules changing, will this change the ability to look longitudinally at the research on the measures for ACOs? And I think all of our panelists might have an opinion on this question as well, but Yelda, I'll start with you.
So yeah, I think that I don't know that it would have an effect on looking longitudinally. I mean, I think if anything, you would probably see a difference at the point of time in which the ACO rules changed. the data, as far as I know, but maybe Travis and Dr. McWilliams can correct me on this. I think they're collecting the data in the same way. It's just the rules are changing, so it shouldn't change the ability to study it. But I do imagine that there will be a change in the outcomes that we're seeing, both in terms of quality and in terms of cost, based on the new changes that are coming.
Thank you. And Dr. McWilliams, I'll just see if you have a response to that question as well.
Yeah, so there's a lot going on in the proposed rule. I think in terms of how ACOs will look performance-wise, that depends a lot on which organizations stay in the program. And the direction of the rules is such that it probably will cause a fair amount of exit among ACOs that are serving populations with high spending because of the move towards downside risk and sort of an average benchmark for all ACOs in the same region. So if we're then left mostly with organizations that already have low spending for their region, the ACO program is going to look really good in terms of comparisons versus the benchmark. But that will actually be a pretty massive subsidy to the participants and not true savings.
Thank you. And Travis, I assume that Elidate has been looking at the new proposed rule as well. Would appreciate your perspective.
Sure. So to some extent, it'll solve our benchmarks aren't counterfactual problem, because the benchmarks performance is going to change so much. We won't be able to really look back in time very easily against the benchmark. I mean, for us, it comes back to the population health takes time. And when we try and relate it to our physicians, we really want, our physicians are really looking for two things. One, they know they can do better, but they do want to be recognized for past performance. So, Dr. McWilliams mentioned that the regional benchmarking has, concerns on the upper side as well, but it does have the benefit of, not recognizing that, ACO, nobody was worried about patients before the ACO started, right? Like, people did care, and PCMH and other things and models were in effect before there was a financial incentive. So generally speaking, we like the way the new regs are going. We think they can create a longer term incentive for our physician-owned practice-based ACOs to both improve and maintain, which is really hard, right? Fighting against the reversion of the mean is difficult. Our biggest concern with the new regulation was new ACOs, right? Like, right now we have 8-9 million people in MSSP. I'd love for that to be double, but with 25% shared savings rates and going to risk after just 2 years and some of the things they proposed, really worry about new entrants. So our bottom line is, we think for existing ACOs, whenever you have a national policy, right, somebody's going to be on the wrong side of an average somewhere, but it's trending the right way. But hopefully they'll make some changes for the finals so that we can encourage lots of new ACOs to come in as well.
Thank you. One of the line of questionings, I think, within the research, generally what we find is there's, additional research to be had. And so the next question, so there is a question that I think is valid for both Dr. Yavapour and Dr. McWilliams around, are you studying some of those next level questions that in your research, particularly around isolating the impact of patient-centered medical home versus the incentives, et cetera, and the effect on physician-led ACOs? Or either of you starting to research that, or know if anyone is starting to do that next level research in that area?
So we're trying to at the Graham Center. I think it gets really complicated with the data, just on a practical level, how the practices or physicians are identified in the NCQA data is different than the ACO data. Also, the NCQA data may not be representative of all advanced primary care practices. So, you know, a lot of times the practices that are able to obtain certification are larger practices with more resources. There's a lot of confounding factors in there that make it hard to study. It's also, I think, hard to study something like PCMH in isolation, given that it's been around for almost a decade. I think there's been a lot of spillover effects of PCMH onto non-PCMH practices. So all these things make it very difficult. I think our analysts are looking at it in a number of different ways. I don't know that we'll ever have a pure study. And I think it would also be nice for us to try to get some private claims data to look at this ACO question in the private payer market. Right now, we just have the Medicare Shared Savings Program contracts. So there are many ways that you can look at it. It is a difficult question. We're trying on our end. And maybe a question that's better answered in a qualitative way. I'm not really sure.
Yeah, picking up on that, I agree that this is a very tough question and tough to get at. You know, I think part of the question is sort of what is working, in particular in some of these physician group models. And, you know, as Travis was saying, you know, we all can tell stories. It's very hard to build an evidence base that really isolates the causal effects of everything that's going on. I think the only way we're going to do that is to fund and implement more cluster randomized trials where, you know, a single intervention can be isolated and randomized, and we can really learn what the causal effect is. In terms of sort of a next level of research, sort of related to the last point I made, I think, you know, we are very much interested in on what the effects of the ACO model are on provider market structure. I think at the outset, people thought, because consolidation was thought to be a prerequisite for success, that these risk-bearing models were going to accelerate provider consolidation. But I think what we've learned is that they're really a viable alternative payment model for some of the smaller primary care focused groups. So to what extent do we actually see these models foster competition and foster entry of new models of care? I think that's something that we'll be trying to get at.
Thank you. Well, we've had, at the end of our time together, we have some really wonderful questions that we're not going to be able to get to, but I understand the PCPCC staff will be organizing these questions, and our panelists have graciously agreed to kind of to answer some of the questions that then can be posted on the PCPCC website. So thank you to all of you. We had great participation today. Thanks to our panelists again for you know, just being willing to share just critical elements of ACOs as well as primary care, and how do we get to the next level of understanding more about what works, because our healthcare delivery system certainly needs to have that answer. So thank you again, and thanks to all of you for participating, and we will now close out the webinar.